Assalamualaikum and good day to the lecturers that will be viewing our group case presentation. My name is Alia Zuhaira, representing Group A1, will further explain about the case that has been assigned to me and my groupmates. What are the best ways to further elaborate on our patient's case than none other through documenting it in the SOAP format? As we all aware, SOAP report functions as a type of documentation to include patients' medical records in a more structured and organized way. Simply to say, it's an effective way for healthcare workers to communicate with one another regarding their patient. SOAP report consists of four parts, that is, the subjective, objective, assessment, and planning. In the subjective part, it is all about the patient details and information that was given in this case. For example, patient's name, gender, race, chief complaint, and etc. It includes only relevant subjective data. On day 1, our case revolves around a man named HF who aged 35 years old, weighs 63 kg and is 5 feet 6 inches. He complained of having a hard time in breathing properly as he was heavily breathing at that moment, accompanied with a fever, and was found to be physically weak. He has a past medical history of having a colon cancer, in which this relates to his condition of developing his current illness, or what we know as the history of present illness in our SOAP report. Patient initially admitted because he will be undergoing a right colectomy due to his condition of having a colon cancer. Post-surgery has caused patient to develop a post-operative wound infection associated with signs of heavy breathing, high temperature, along with physical weakness. Due to his infection, he was treated with a surgical drainage with IV cephalosporin. Wound sample was taken and it was discovered to be a Staphylococcus aureus, which is a type of bacterial strain that is resistant to penicillin and cephalosporin. This results in the change of antibiotic treatment to IV vancomycin that is much more appropriate for this case of MRSA infection. After 2 days of IV vancomycin therapy, patient was observed to experience fever and develop redness around the areas of his chest and neck, in which he was further diagnosed with the red man syndrome. He had no known drug or food allergies and no social history. From his history of presenting illness, we can gather the information here that our patient has a medication history of previously being treated with IV cephalosporin due to post-operative MRSA wound infection. So that sums up our objective part in the SOAP report. So let's move on to the objective. In the objective part, it includes relevant objective data only. The differences between subjective and objective is that objective data can be measured directly while subjective data cannot, as the information under subjective data is obtained directly from the patient itself. For example, the patient said that he has a high blood pressure, so the patient's blood pressure that will be taken at that moment to be observed will be put under the objective part. Based on the patient's information in this case, the vital signs are in normal limits. Same goes to the respiratory rate. And regarding the patient's laboratory findings, it was found that the patient blood counts is normal, along with normal renal profile in which patient serum creatinine is 0.7 mg per deciliter and his creatine clearance is 134 milliliter per minute. The most important in the laboratory findings is the culture and sensitivity test. In this test, culture of the wound reveals Staphylococcus aureus, which is a gram-positive bacterium based on the observation of sensitivity tests that showed a resistance towards penicillin and cephalosporin. Now, let's move on to part A, which is the assessment made on the patient. This section is where our group assimilates all the information we obtain from the subjective and objective areas and applies it to standard practice as defined by the evidence-based medicine. Firstly, on the initial assessment, we found that this case lacks of oxygen saturation data value. Previously, patient complained that he was breathing heavily and it was assumed due to the infection. However, the oxygen saturation value was not provided, in which this enables us to fully justify whether patient is experiencing hypoxemia. According to Shai in his journal, below 90% is considered for one to be experiencing hypoxemia. Hence, we assume that this patient oxygen saturation value might be below than 90%. Next assessment that we notice is the incomplete patient's chemotherapy course and regimen. No drug information on the chemotherapeutic agent consumed by the patient was given, along with no data was also not provided involving radiotherapy, adjuvant, or neoadjuvant. Why is this information is crucial? Well, this is because according to Wiffen's research, cancer patients usually take pain suppressions such as morphine and steroids that acts as an antiemetic drug. Despite that morphine can be used as a pain suppression, it can also cause constipation, nausea, and vomiting as its side effects. Whereas for steroids, their side effects usually involve fluid retention, edema, and moon phase. Edema formation and intravenous fluid administration, it contributes to a significantly increase in patients' total body water, in which this increases the volume of distribution of hydrophilic antimicrobial like vancomycin. The clinical importance in this is that if the initial loading dose is not increased, it might take 1 to 2 days before stable serum concentration are reached, thereby compromising its clinical outcome. On our third assessment, we also noticed that there is no specific value for vital and laboratory data. In this case, specific data value for vital signs, respiratory rate, musculoskeletal, full blood count, and other laboratory tests was also not provided, in which this could affect the overall monitoring of patient condition and progresses. For the fourth assessment, it is on the appropriateness to initiate surgical drainage and intravenous cephalosporin treatment. Initially, patient was treated with surgical drainage and intravenous cephalosporin. The rationale behind this is that the surgical drainage is used to decompress or drain either fluid or air from the area of surgery to prevent pus or dead space. According to Woods, intravenous cephalosporin-based empirical treatment is used as a first line for post-operative wound infection. The fifth assessment made is on the appropriateness of substituting intravenous cephalosporin to intravenous vancomycin treatment. The rationale behind this switch is due to vancomycin is the only effective treatment against gram-positive cocci. Hence, once the culture of wound tests, it reveals the presence of Staphylococcus aureus, which is a gram-positive bacterium, in addition to the sensitivity test that shows presented bacteria in the patient to be resistant to penicillin and cephalosporin, or what we call as MRSA, Therefore, vancomycin is the most appropriate antibiotic treatment that can be used for this patient. Next, for number 6, it is the thorough assessment on patient's available information to calculate the intravenous vancomycin dose. Based on the case study, weight, and height information available allows us to calculate patient's BMI for dosing weight. In addition to that, volume of distribution, elimination constant, creatinine clearance, tau, CP peak, CP through infusion time, and sampling time are also available to enable us to calculate the maintenance dose. The IV line to administer vancomycin was already prepared in this case. Next assessment involves in the target CP peak and CP trough. As we all know, the patient have past medical history of having a colon cancer. Hence, it was presumed that he already underwent a chemotherapy. Generally, chemotherapeutic agents are nephrotoxic, thus, it may increase the risk of acute kidney injury to this patient. Therefore, the chosen minimum target range for CP peak and CP trough is 25 mg per liter and 10 mg per liter respectively. The lowest range of CP peak is used on this patient to lower the risk of nephrotoxicity due to the side effect of both vancomycin and chemotherapeutic agent. CP peak value is then used in the formula of maintenance dose calculation and determination of AUC over MIC ratio. CP trough value refers to the minimum therapeutic concentration that is effective to the patient. It also reflects the minimum level needed to kill for the microorganism. The lower value than CP trough can increase the risk of therapeutic failure and drug resistance. On the other hand, high concentration of vancomycin plus low drug clearance can cause accumulation of the drug in the body and will lead to toxicities to the patient. So, if the vancomycin concentration level is within the therapeutic range, the patient may have an effective treatment, low risk of side effect, and less likely to be prescribed with a subtherapeutic effect. Next assessment is about the side effect of vancomycin at the site of injection. Vancomycin has direct irritant effect due to its low pH, which about 2.8 to 4.5. It may increase inflammation of the vein causing phlebitis. The last assessment is on the inadequate energy requirement and fluid electrolyte. The patient is currently on nil per mouth, which is a traditional nutritional management for patients that have underwent a right colectomy due to colon cancer. This is to avoid any risk of infection with the early exposure of GIT to nutritional sources. So, this event will increase the risk of dehydration, weight loss, electrolyte imbalance, reduce in energy, and slow recovery from the surgery. In this case, it also did not have any drug-related problems. Now, let's move on to part B, which is the planning. Referring to the assessment on the lack of oxygen saturation data, the patient should be closely monitored due to patient experiencing heavy breathing caused by the infection. Regarding on incomplete chemotherapy course and regimen, we should refer to the general physician to get a complete patient data on his medication history, surgery history, and the drug tolerance. We need to monitor carefully the side effect of chemotherapeutic drugs that has been consumed by patient. We also need to monitor the kidney function and ensure the serum creatinine and creatinine clearance is always within the normal range. The patient should also be monitored
about the side effect of steroids if this patient has been taking steroids beforehand. The steroid monitoring includes the presence of signs and symptoms like edema, fluid retention, or moon phase. Taper the dose if suspected any of these signs. We also need to inform the patient regarding possible side effects of morphines, such as constipation, nausea, and vomiting, if he has not been acknowledged yet. Regarding the availability of patient's information, use all the information given to calculate the dose.
In order to calculate the IV vancomycin dose, here are the methods that we use. First, it involves the calculating of BMI, the VD, creatine clearance is already stated in the case, calculating the KE, tau, selecting the conventional dosing regimen, and then calculating the ideal maintenance dose, calculating the AUC24, and after finding out the value of AUC24, the MIC for MRSA infection is equal to 1, therefore the value of AUC will be divided over MIC, leaving us to the value of 398.4. So the value of AUC over MIC value is more than 124. This means that the dose that we have calculated is effective for our patient. So our recommendation is to use 8 hourly intervals because vancomycin is time dependent. Shorter time interval with 1 hour infusion is more recommended to maintain the concentration of vancomycin with AUC over MIC of more than 125. The last plan should be done to the patient is regarding the inadequate energy requirement and fluid electrolyte. Nil by mouth is traditional nutritional management for patients that underwent right colectomy due to colon cancer in order to avoid any risk of infection with the early exposure of the GIT to any nutritional sources. Therefore, this will increase the risk of dehydration, weight loss, electrolyte imbalance, reduce in energy, and slow recovery from the surgery. Therefore, we suggest the patient to receive Cavivan parenteral nutrient that contains combination of amino acid, electrolyte, dextrose, and lipid injectable emulsion. We first need to calculate the BMI, proceed with energy expenditure and actual energy expenditure. After that, we can calculate the PN requirement, which consists of calculating the total calorie requirement, total fluid requirement, macronutrient requirements such as protein requirement, non-protein calorie, MPC over N ratio, and ratio of the carbohydrate and lipid. For the micronutrient requirement, it involves the calculating of electrolyte requirement. Since the lab value was not given, therefore, we cannot calculate the electrolyte corrected value if the value is out of the normal range, so we decided to give daily maintenance requirement as seen in the table. Multivitamin requirement is also calculated. We use 5 ml per vial of Synavit that consists of both water-soluble and lipid-soluble vitamin in whole vial. Next, the trace element, we use 10 ml per vial of multi-trace that consists of zinc, copper, manganese, selenium, and chromium. We also need to check for the osmolarity, and after calculating the osmolarity, we need to recheck for route of administration. In this case, the central administration is more appropriate because our calculated osmolarity of solution is above than 900 milliosmol per liter. We also select a ready mix preparation of parenteral nutrient, which is a convenient packaging. We give smooth Cavivan Central bag number 5 where the total volume is 1.5 liter and the calculated micronutrient and macronutrient requirement is almost close to the value in parenteral nutrient bag number 5. The infusion rate that we have calculated is 78 ml per hour. Therefore, we use infusion rate of continuously for 24-hour infusion of 78 ml per hour, which is about 26 drops per minute. We are done with day 1. Now, let's take a look on patient's condition on day 2. Same as previous, we will further explain the progress on our patient's condition according to SOAP format. Firstly, for the subjective part, all the information remains the same. except for patient's chief complaint, history of presenting illness, and diagnosis. This is because after 2 days of intravenous vancomycin treatment, the patient was observed to experience fever and develop redness around the areas of his chest and neck. He was diagnosed with red man syndrome. He had no drug or food allergies and no social history. Moving on to the objective, upon observations made, the vital signs such as the blood pressure of the patient is observed to be normal, in which his BP was 110 over 60 millimercury at night and 120 over 80 millimercury on the next morning. The heart rate for this patient is also normal on day 2, which is 95 beats per minute. However, respiratory rate of the patient was slightly higher than normal, showing 24 breaths per minute, as the normal range for respiratory rate is within 12 to 16 breaths per minute. Based on the laboratory findings, there is no data for full blood count information. He has a normal renal profile of serum creatinine, which was 1.1 mg per deciliter, but no data was given on the creatinine clearance. Other laboratory data like sodium, potassium, urea, arterial blood pH were within the normal range. The observed C-peak and C-P trough are 20 mg per liter and 8 mg per liter respectively. The targeted C-peak and C-P trough are 25 mg per liter and 10 mg per liter. Throughout assessing the patient, we found out that firstly, the CP peak and CP trough did not achieve the expected target. After 2 days of IV vancomycin therapy, the observed C peak and C trough failed to achieve the desired value. The observed C peak is 20 mg per liter and C trough is 8 mg per liter. According to Martins in his research, optimal trough concentration should always be maintained above 10 mg per liter to avoid the development of bacterial resistance. C-peak and C-trough of vancomycin fail to achieve the target can be due to change in the creatinine clearance of the patient and the volume of distribution. Serum creatinine shows an increase from 0.7 mg per deciliter to 1.1 mg per deciliter after 2 days, indicating a decrease in the creatinine clearance or reduction in elimination rate. This is because an increase of more than 50% of serum creatinine from the baseline can indicate an acute renal injury or nephrotoxicity. Other than that, a temporary increase in serum creatinine can also happen due to hydration. Therefore, there is a probability that this patient experienced a problem with his kidney function or he is dehydrated. The volume of distribution from population parameter does not actually reflect the actual volume of distribution for the individualized patient. Next assessment is the patient was reported to develop redness around the areas of his chest and neck with a slight decrease in blood pressure from the optimal level and a fever with a temperature of 38.5 degrees Celsius after receiving an IV vancomycin treatment. Rashes on the upper body accompanied by low blood pressure and fever are the common side effects of IV vancomycin treatment, in which this indicates that patient is experiencing a red man syndrome. Red man syndrome can occur after receiving IV vancomycin due to a high infusion rate of administration, which is faster than 50 mg per minute. From the calculated rate, the infusion rate for this patient was 15.82 mg per minute. This value is higher than the recommended rate of infusion, which is 15 mg per minute, resulting in the development of red man syndrome. For the third assessment, sodium level is higher than normal, suggesting that the patient is experiencing hypernatremia. Hypernatremia can occur due to dehydration that causes by insufficient consumption of fluid intake or kidney dysfunction. The patient may experience thirst, nausea, and loss of appetite. Since the patient had underwent a right colectomy because of his colon cancer, thus he has a possibility to be dehydrated. Since the patient cannot consume food orally, he needs to receive fluid management to reduce his sodium level. However, fluid management must be monitored because it can cause hyponatremia if there is an excessive fluid intake, especially if this patient has a kidney problem. This is because kidney problems can cause water retention. The fourth assessment is on the higher respiratory rate. Respiratory rate can rise to compensate for metabolic acidosis. This patient value of arterial blood pH is borderline between normal and low pH value, which is 7.35. Thus, the patient has a high risk in experiencing acidosis if the value continues to decrease below the lower limit. Signs and symptoms of acidosis include rapid heart rate and a high respiratory rate. Thus, the arterial blood pH of the patient must be monitored. The fifth assessment is the inavailability of full blood count test data. A full blood count test should be conducted to determine whether the infection has resolved or not by looking at the result of the white blood count cell. Other than that, wound sampling and culture and sensitivity tests can be conducted once again to check the presence of infection. Unlike day 1, our patient was experiencing a drug-related problem on day 2. Firstly is the inappropriate infusion rate of IV vancomycin. The patient, we know that he experiencing a red man syndrome after 2 days receiving the IV vancomycin, showing signs of the side effects of red man syndrome such as rashes and fever. Therefore, IV vancomycin for the patient need to be temporarily held until the symptom for red man syndrome resolve and continue giving back the medication by using the normal infusion rate, which is 15 mg per minute. The next drug-related problem is the inappropriate dose of vancomycin. After 2 days of IV vancomycin, the observed C-peak and C-trough failed to achieve the desired value. The observed C-peak is 20 mg per liter and C-trough is 8 mg per liter. The CP trough value below 10 mg per liter can increase the risk of bacterial resistance. C-peak and C-trough fail to achieve the target may be due to change in creatinine clearance and volume of distribution.
Assalamualaikum, and I'm Shafiq. I will be the one to take over from here. Now we move to the P part or the plan part for this SOEP notes. We divide the plan into two parts, which are long-term therapy and short-term therapy. For the long-term therapy plan, the plan for C-peak and C-trough that has not achieved the expected target in day 1 is then adjusted for a new IV vancomycin dose. Therefore, we need to recalculate the new KE and also the new VD for this patient for reconfirmation for his individualized therapy. So first, to calculate the new KE, by using the given formula, we will get the new recalculated KE, which is 0.17 per hour. Next, to calculate the new half-life by using the formula of 0.693 over the new calculated KE, which is 0.17, we will get a new half-life of 4.08 hour. Next, to calculate the new tau, which is tau is the time interval between the two dosing time, we will get 6.4 hour, which is approximately closer to 8 hourly regimen. Then, to calculate the maintenance dose, we will first require the new VD for this patient. After a thorough calculation, we will get new VD for this patient of 58.7 liter. Next, to calculate the maintenance dose, we will first need to substitute the relevance value into the formula, and then we will get new maintenance dose of 1000 mg in every 8 hourly regimen. So next, to calculate the AUC over MIC, we will first need to calculate the clearance. The clearance will be using the formula of elimination rate constant times by the new VD, that we will get the clearance of 9.98 liter per hour. Next, to calculate the AUC over MIC, which is the total maintenance dose per day divided by the clearance times the MIC, which is MIC for MRSA infection, will be equated as 1. We will get AUC over MIC of 300.6, which can be deemed as an appropriate dosing regimen for this patient, as it is more than 125. So based on our calculation, we would like to recommend to use the 8 hourly interval because vancomycin is a time-dependent drug. A shorter time interval with 2-hour infusion is more recommended for this drug to maintain the concentration of vancomycin with AUC over MIC more than 125. For the administration of IV vancomycin, we will first need to set the intravenous line for this drug. We will first need to set the infusion rate, then inserting the needle at the IV line, followed by starting the IV infusion containing the vancomycin drug to enter into the patient body by a central line. Then infuse IV vancomycin of 1000 mg over 2 hours in 8 hourly interval with infusion rate lower than 15 mg per minute. After administration of IV vancomycin, some monitoring parameters shall be done. Some of the parameter is the continuity from day 1, which include vancomycin peak and trough level monitoring, BUN and serum creatinine monitoring, and also monitoring of patient weight. Some additional monitoring parameter will include the urine output for this patient, which is done by measuring and monitoring urine output of this patient in a daily basis. Next, on the baseline and weekly audiogram is to assess patient hearing issue because vancomycin can cause ototoxicity. Assessment can be done by using audiogram weekly. Risk factor of ototoxicity may include pre-existing hearing problem, any underlying renal dysfunctionality, old age, and excessive peak concentration. Patients shall be checked for sign of phlebitis and extravasation. IV line need to be monitored every 2 to 3 days and change the tubing for both vancomycin and parenteral nutrition with proper cleaning, which is to avoid contamination and also the risk of infection. Vancomycin has an irritating properties that can cause inflammation of the vessel at the injection site, which checking for sign of phlebitis and extravasation is recommended for this patient. Next, on culture and sensitivity is done to investigate organism susceptibility toward vancomycin and also to identify the clearance of bacteremia. Next, on the white blood cell count, which is done to monitor the infection issue, the normal total white blood cell count, the normal hemoglobin count, and also the normal platelet is as stated. Next, patient shall be checked on the symptomatic improvement such as from his vital signs, hemodynamic stability, Glasgow coma state, and also alertness level for this patient. For the short-term therapy plan, firstly, we will need to overcome developed redness around the area of the chest and the neck, the low blood pressure and fever. We will need to withhold the dose until the symptom disappear. Then we will continue with vancomycin regimen with appropriate administration rate, which is below 15 mg per minute. Next plan will include to give patient fluid management to reduce the sodium value in managing hypernatremia. However, make sure to always monitor the sodium level because if too much fluid can lead to hyponatremia. Other than that, monitoring of input and output chart of the patient is also important so that we can manage the fluid in the patient body and detect whether there is a risk of water retention. The next plan is to overcome the high respiratory rate. Monitor the arterial blood pH so that it does not fall below the lower limit because it can cause metabolic acidosis if it reduces even further. Other than that, monitor the respiratory rate of the patient because a higher respiratory rate is a symptom of metabolic acidosis. Lastly, the plan is to overcome the unavailable data of the full blood count test. We'll need to conduct the full blood count to check the level of white blood cells to determine whether the infection has resolved or not. Other than that, is to conduct the culture and sensitivity test once again to check the presence of bacteria.
That's all from us. Thank you.